This is the Health and Politics podcast, Prevention is the New Cure, live from Digital Health Rewired.
And that's with former ministers James Bethell and myself, Steve Brine. James, this episode is sponsored by Mastec. Mastec is an international company with a full range of digital data and technology services that change the way individuals interact with healthcare systems. They've got a 25-year history of working with the NHS and have been trusted to deliver significant national IT infrastructure and data projects across the UK public sector. You can find out more at mastec.com.
You read that very nicely. Thank you, Mastec, for supporting the show.
Indeed.
So this week we're coming to you from NEC in Birmingham, where 4,000 digital health leaders are gathered for Digital Health Rewired, the biggest NHS tech and data conference of the year.
Yeah, indeed. It's really good to be here, James, isn't it? Huge shout out to Neil and the crew at Digital Health for putting it all together, inviting us along to be here in their new podcast cafe. I mean, Rewired, I came once as a minister, James. It seems to get better every year, and we've been out on the exhibition floor all morning, haven't we? We've seen some of the demos, we bumped into a lot of old friends. What sort of caught your eye since you've been here?
There's real energy here. I would say, the organisers told me there were 20% more people. I would say that there are a few more CEOs and senior figures than I would have normally seen. I sense appetite amongst the smaller apps and the startups, that they get the feeling that the NHS is really listening to them. I think some of the bigger companies maybe think the EPR work is behind them for the moment, and so they're slightly wondering what are the big chunky projects on the horizon. And it's just really nice to see some of my favourite people here. Gary from Dell, Oliver and Gareth from Haviland, Benedict from Sonome, Elle from Heim, and Mo, of course, great Mo from Patients Knows Best. He's basically the guy at the moment, isn't he?
Yeah, well, they've got the big Mo, haven't they, Patients Know Best?
They have.
Now, I've been sort of wandering the floor like you, chatting to people, just trying to get a sense of how it compares to recent years and listening to some of the presentations that have been going on. And you're right, energy is definitely the word that you get here. There's a huge number of... It's a very positive sector, isn't it? There's a huge number of startups here, backed by a lot of, obviously, investment. And you see that because they're here then alongside the big boys. I suppose the question is, how many of them will be here in 1 to 5 years' time? And that's the ecosystem, I suppose, that is digital health. But I think if I was critical, I'd say that some of the conversations feel very sort of software focused and the tech focused more than they are the patient and the outcome focused. And I think that's always the challenge. And a couple of people who are very aware of their own limitations have all said that to me while I've been here wandering around. So I mean that's ever the challenge, right?
I sometimes make the comparisons with the digital music revolution that I lived through.
Yeah.
And you had that at the beginning where it was a lot of tech companies talking about musical tech. You go today, and it's all about the producer, the musician, and the listener, and what they're doing, what they're co-creating. And it's pivoted to really being about the consumer rather than about the bits and bytes.
Yeah.
We're not quite there yet on health, I don't think.
Yeah. Can I say how nice it is to do the podcast where I can actually see you?
I know.
Literally, normally we're online. Just before we get into some of our subjects, and then we'll introduce our guests. So, bit of listener feedback, just one this week actually, James. So Susan Jebb from Oxford University, where you were last week at the Patrick Vallance lecture that we talked about, obviously chair of the Food Standards Agency, she sent us this lovely message. She said, I was listening to your podcast this morning as I walked to the station. I was very, very surprised to hear our department name-checked in relation to Patrick Vallance's lecture. Thank you. They will be delighted. I was amused by the thought of Patrick as an apex predator, which is what you called him.
Yes.
He seems too nice to eat anyone.
Oh, he's very nice. But he does have moves.
He does have moves. Okay, this was the bit you'll be pleased with, James. She added, I'm very pleased on the very rare occasions that I run the 5K park run in under 30 minutes. This was because I was complaining last week that I can't get under 30 minutes, but you were telling me that I'm doing okay at 28.
Well, I was giving you a pep talk, but it's very encouraging that the chair of the Food Standards Authority, Food Standards Agency, is doing under 30. That's a good thing to know.
Right, let's crack on. This is the Health and Politics podcast. It's called Prevention is the New Cure. We're both former ministers. Try and give a bit of insight into decision making, how it's made, and try and get out and about on the road. We were at Confed Expo last year, and we're here at Rewired, and we've got quite a lot more that we're going to be doing as we travel. So this week, James, we're going to start with two big stories from the world of prevention. So first of all, you've got a new commission. We touched on it last week in our meningitis episode, but it's certainly out there now to tell us about. And then we're going to touch on the government's plan to move the NHS out of hospitals and into your neighbourhood.
Then we turn to all things digital. We've got two fabulous guests sitting next to me right now. Sonia Patel, the woman who spent 6 years digitising the NHS and just this month became the government's interim Chief Technology Officer. So we're going to ask her about Rewired, the £7.4 billion NHS digital plan, and what comes next.
Yeah, and then sitting between Sonia and yourself is Helen Clifton, who looks after products and platforms at NHS England. We're chatting to her around the same time. And then we're going to finish with a story about one mother's campaign that has already saved hundreds of lives. Just to say, if you want to WhatsApp us, we'd love to hear from you. People do. Send us a voice note and we'll play it out in future show. The number to do that is 0333 404 6507. Now, back to the top, James. Big response over the last week to our meningitis horror episode. Interesting, I see that the UK Health Security Agency is saying on Monday they feel the outbreak has now peaked. Within, obviously, we talked a bit about vaccine health last week. We're just going to take on a bit more now briefly. So over to you, James. What is it you've been working on?
Well, the UK's vaccination system is an enormous triumph. It is public health at its best, but it does have gaps, and in the UK, bigger gaps than some other countries. This meningitis outbreak has exposed delays in the alerting of patients, inequalities in who gets vaccinated and when, and a system that still struggles to reach the communities most at risk. It is, I'm afraid to say, one of a sort of rolling mini-epidemic pattern that we're growing to annoyingly get used to. So that's why I'm really pleased to be chairing a new commission on access to vaccines from the Royal Society for Public Health, where I am a trustee. It's a really great initiative. We've got some kick-ass commissioners, including JVT, Jenny, the former CEO of UXA, and June, former CEO of MHRA. We're going to really focus on this question of what are the problems with getting access to vaccines. And that's a very practical question. It's about digitising appointment booking. It's about thinking about what the GP's role should be and whether we can look to the workplace and employers to be supporting it. It's about trying to maintain records. I've got 4 kids. Trying to maintain their vaccine records I find absolutely impossible with my 4 red books. It's absolutely ridiculous. So it's really looking at all of those practical details. And we're also going to particularly look at adult vaccines. There is a very good House of Lords focus on children's vaccines, an inquiry that began a couple of weeks ago. So we're going to look at adults. And the reason for doing that is the new technologies are putting up really interesting new vaccines for things like cancer, but also our insight on things like cardiovascular risk, dementia risk, oncology risk, suggests that your virology, the diseases that you've caught during your life, and the impact on your immune system can have a real bearing on your long-term healthy longevity. The Shingrix vaccine is a really good example of that, 20% reduction in the chances of dementia later on. So we really do need a system that gets adults into vaccines quickly, easily, at low cost, and at a mass population level. So, yeah, we're going to be working hard on this.
Yeah, I'm just you, just
yes,
because...
You are.
Sorry, just 2 things on it briefly. I think confidence in vaccines has been shaken since COVID, and the numbers, as we discussed last week on the ACYW vaccine of meningitis, have gone down by a good 10% since the pre-COVID levels. So there's that access problem, which is obviously logistical, which is getting jabs into the arms of people and deprived communities in particular. So there's that, once the JCVI have agreed it and once the government have agreed to fund it, of course. But my sort of challenge to you and your commission is, what if you recommend expanding significantly the childhood vaccination schedule or the MENB schedule, which I think there's a chance that you might? It's the who pays question, and that is a difficult one in opposition. You should rightly always be asked that question, and in government you have to answer that question. So, if your commission's going to come up with who pays, you're going to have to answer that question, aren't you? Yes,
it's the critical question. By the way, mini epidemics like the one we've got at the moment are quite expensive. They cost a fortune in the reaction, the lost productivity, the long-term impact on those who are infected. So there is a very important question about how JCVI assesses vaccines and on what economic model. But there's also a question on how do we account for high rates of infection and the long-term impact on the population. So yes, a lot of this is practical and about day-to-day access for hard-working families, and some of it is economic, on how do we challenge JCVI, OBR, HMT, NICE, the economic drivers of our health system, about how they're really accounting for disease.
Yeah, well, good luck with it. I mean, we did this big vaccination work on the Health Select Committee, and I was always told that next to clean water, vaccination is the biggest impact you can make on public health. So we need to do better on it, clearly.
And your 5K run.
My 5K walk / run / be pulled by dog. Interesting, just finally on vaccines, I noticed that BBC are reporting this morning, Wednesday as we record this, that there was indeed a 2-day, because we got a bit of criticism on social media for our comments last week around the meningitis outbreak, and I think we were right. I think there was a delay, and that's being reported today by the BBC. There was a 2-day delay in reporting that first case, which is contrary to UXA's rules. So, I think they need to look at that, and the Health Secretary has been out on the news this morning talking about it, so he needs to look at it. Just one other thing before we bring in our guests. The government finally published last week, James, the Neighbourhood Health Framework, which sounds ghastly.
Oh,
it sounds
Steve.
terribly. Well, it sounds terribly dull, but it actually is really important. So let's agree on that bit before we disagree on everything else. So it's pretty much the delivery mechanism for the entire 10-year plan, which Jim Mackey was on our podcast last month talking about. And the ambition's bold. So you've got 90% same-day GP access for urgent cases by March 27. They're promising a quarter of hospital referrals diverted through single points of access, and 250 new neighbourhood health centres by 2035. So this is how they say they're going to make the shift from hospital to community that Rewired's been talking about over the last couple of days. It's exactly the kind of shift that digital infrastructure is going to facilitate to make work. The question is whether it's a framework or it's a fantasy. And I know you are more positive than grumpy parkrun me.
Yes. Well, listeners may detect a slight difference of opinion here. I have a puppyish enthusiasm for this framework.
Puppyish.
Yes,
nice.
And any conversation about pivoting towards prevention and the building of better public health capability in this country ends up with neighbourhood health. And you would wish to have this kind of implementation plan at your disposal, and you would like to run really hard at it. So I am incredibly excited to have it published. We're not going to go into the detail of it because we're going to talk about other things, but the fact that it exists makes me very happy. But I should share with listeners that Steve takes a slightly different view, which is that it is just another big waste of public money on publishing pointless documents, of which we are very guilty as a country, and there seems little chance that any of this is going to happen anytime soon.
Well, no, the reason I'm being circumspect, and I know sometimes, I'm accused of sort of being the voice of the producer here, is that, we talked about GPs and how grumpy they are, and the BMA GP committee at the moment are grumpy, and they're grumpy because they think they should be at the heart of designing neighbourhood health. And I kind of think they're right, actually. Yes, they've got to change their MO, but if you're creating neighbourhood health centres, well, aren't they called general practice? And so I just think that the government are cross with GPs, and they're having this argument with GPs, and we're going to go down this road of neighbourhood health centres. But neighbourhood health centres are actually known as your GP centres, and I just think they need to heal that wound and bring it back together if it's going to work.
I at least 50% agree with you.
Oh, well, progress.
I happen to also think that there's scope for innovation here.
Yeah.
Can I say a shout out to the team at Heim, who have just closed a £2.5 million round fundraising for their digital community nursing platform, something that wasn't really spawned from the current GP community, but I think is the kind of tech that this framework needs and will have a big impact. For full disclosure, I'm an angel investor in Heim, and I can't disguise my enthusiasm for the business. But listen, Steve, we should unpack this at another time when we have more time.
We will do, yeah. It's a good band called Heim, by the way. Two sisters.
There we go.
Yeah. You would know this. Music. Anyway, listen, you've already touched on our two guests. Two brilliant guests. James.
Sonia Patel
yes.
is the Interim Government Chief Technology Officer, based at DSIT, working with GDS. Everyone at this conference will know her as the former NHS England Chief Technology Officer, and she is someone who's made a massive impact on the British health system. We're very grateful for her being here today.
Yeah, and also Helen Clifton, who I touched on earlier, Executive Director of Products and Platforms at NHS England, which is actually a fancy way of saying that Helen's effectively responsible for how the NHS shows up in people's pockets. and whether digital actually delivers prevention, so not just convenience. And Helen was also once the Chief Digital Officer for the Australian Broadcasting Corporation, which I love that. I love that stat. I think it's a great stat, that, isn't it? So Sonia, you've been at Rewired before. I know you've been here for the last couple of days. In a different capacity, you've been here before. What's the vibe? What's caught your eye? And thanks for coming on the podcast.
Well, delighted to be here. I think I was thinking, would this be my last Rewired? But I've had such an affinity to healthcare and NHS.
That's very nice.
I will be making a return. No, I've been coming to Rewired for the best parts of 10 years now. And we had very, very simple stalls. And you could see that the kind of both, the hum remains, so there's a real energy in the room, but actually you can see the stand wars now, right? They're just getting bigger and better.
Yeah.
Better coffee, orange juice even, and cakes and chocolates as well. And I'm seeing a real turn, actually. We used to get sort of core infrastructure providers. We're now getting technology providers that really want to make a difference in terms of actually how care is delivered, where, to whom, by whom as well. Listening into your points around actually, is it consumer-led still? Well, I think we're at that inflection point at the moment that we're still getting to terms around. We've still got some core infrastructure in the NHS that we just need to get the basics right for in order to kind of take that real next step after the work that Helen has done on the NHS app to go really further into how we support prevention, particularly around neighbourhood care. But actually, we've set some of the foundations now. And clearly there's a lot of energy. We've got to capitalise on it in the best way possible with I'd say limited funding. It is reasonable funding for what we need to do over the next few years across healthcare.
I mean, it's pretty massive funding. We've had the announcement of a £7.4 billion plan. That's a stonking amount of money. It does get spent pretty easily. Is there anything that you would like to say about that, and you've had a role in securing that money?
Absolutely. So whilst it is the largest investment we've had to date, I mean, the last largest investment we had was in the EPR investment, which I led the programme for at the time, which is around 2.1 billion, just to put the core EPR infrastructure now. I think with the rate of inflation that you see and actually the need to really solidify our plans, actually 7.4 doesn't go that far. So we do need to ensure that we are spending that money wisely, but also investing it at the right unit value. So that will mean that we're looking at change across healthcare where we've bought technology individually or separately and buying that in a way that's more meaningful. Also being really considerate about what should be done once, and I know Helen's doing a lot of work nationally to see there are some things that are just better done once, just because of the way our patients move around. They're not dedicated necessarily in any one geography, and actually we're going to create great meaning and modern services for our patients. It may not be that they're treated in their residence, it might be closer to their place of work, or they might be a carer for someone that doesn't live close to them. So there's lots of considerations here around actually the mobility of our nation and thinking about how we create the right architecture for the future. So in terms of 7.4, I think we need to continue to optimise the investment we've put into electronic patient records. So our clinicians are finding joy, be it through ambient voice, AVT, or improving the workflows. The second then is really actually connecting the NHS up. So be it through single patient record or our data plans, it's just to ensure that we are connecting the data that needs to follow the patient. And then lastly, really powering through what we can provide. And I'm sure Helen will share this with you, but what we do to support our patients, but more importantly, how we support our patients to improve the nation's health. And that's really important. So, once you start consumerising your ability to deliver healthcare, things like NHS Online, also providing sort of preventative services and really making neighbourhoods really work becomes a reality.
And in that consumerisation, is there anything either here or what are the manifestations of that you're particularly fond of or you would like to point at?
So I read some recent studies around actually what would modern public services or modern government services look like for the public. And increasingly, they want more, the public want more from the NHS in terms of digital services. And we have to also recognise, whilst there may not be a generational divide in terms of how technology is used, there is definitely a generational shift of more of a public and consumers using technology in their fingertips. So accessing healthcare, getting their right appointments. So we do need to not just put technology in a corner. Technology can't be for technology's sake. We really need to make sure that they're engineering much more meaningful services that not just provide access to healthcare, but also allow someone to inform how they can take responsibility or charge of their own health and well-being.
Yeah, it's so good to hear you say that, Sonia, and that sort of perfectly leads into you, Helen. I mean, we talk about digital enabling prevention, don't we? But where's the hard evidence that NHS digital projects are actually changing behaviour or improving uptake, as opposed to doing clever things technically? Well, just give us the hard evidence, because you've heard the start of our podcast today how grumpy I am, and it's because I can't do park run. But hard evidence that it's changing behaviour. That's the challenge.
I think it's really important that when we're thinking about the role of digital, we're really thinking about that end-to-end service. So yes, it is what shows up for the patient or a citizen in terms of the NHS app, but actually it's also the back-end systems, particularly in prevention, which we've talked about before, are very legacy 30-year-olds that also need to be modernised, and the data needs to be centralised so we can be much more efficient in terms of how we run the screening and vaccination programmes in particular. And then not just looking at how we run them today, but also thinking about how we use innovation and a lot of the digital kind of capabilities we see across sector, whether it's in retail, media, banking, and how we use some of those attributes to actually change your relationship with the NHS through digital, which is quite different in prevention because it's not a short-term relationship. When people go to the doctors, they've got something wrong with them.
Yes.
We're trying to bring people into the ecosystem and really take more responsibility from themselves, and actually digital definitely supports that. So some of the stats, you want some hard stats. We need more belief in what is possible. So, we've already shifted digital communication to 90% digital communication across vaccinations and across bowel and cervical screening. And what we see there is an uptake in the number of people showing up for appointments. Not only do you see what you're eligible for because you're notified about that, but also it reminds you when your booking is, so you show up. And we've seen already, since we've launched that, just for cervical, 70,000 more people actually showing up for their appointment.
Well, that's very good.
I've got some more kind of stats. Some things we're just bringing to the market, like at-home testing for HPV. That's already kind of live in Australia, and we've got similar impacts through our kind of testing, but we're rolling that out this summer. And what that has shown in Australia, that if you enable home testing, particularly actually for groups that actually don't want to engage face-to-face with the health service. So that does reach out to our underserved
the inequalities
issue, because people think digital is a divide. Actually, what we've seen is digital is an enabler. And in Australia, they've got 14% increase in the number of people being screened for cervical through enabling home testing.
Very good.
But I've got a very long list, and so I won't take you through all of them.
Will you send it to me, and we'll put it on our LinkedIn?
I'll happily put it on.
Yeah, because there is some really powerful evidence, basically. Yeah.
Fantastic. So, Sonia, I hear the message that a lot of this investment is in background infrastructure. It doesn't immediately manifest itself to people at home, and but we should have confidence that it is enabling and providing a platform for future benefit. What's the rough schedule for that? When do you think the consumer is really going to see a radically different experience? And what kind of year, like 2029? Before then, for instance, what might the consumer, voter, taxpayer see before then?
Well, given this rate of change of technology at the moment, just genuinely in the technology sphere, things used to take usually 2 to 3 years in
Yeah,
terms of turns of cycle to move from one technology to another. You've probably evidenced yourself or experienced yourself actually with the rise of kind of consumable AI, that's really now changing the speed at which we can offer up, whilst we're also lifting the background infrastructure, a way of being able to provide incremental benefit. So Helen is also sharing there is a significant piece of work we're doing to uplift our national infrastructure, but where possible, we start providing incremental benefit, because that is super important. We can't just wait for the infrastructure to be fixed. We've got way too many opportunities and also way too many problems just to wait. So by 2029, I definitely think we will have a large proportion of the population using, by default, the NHS, be it on your phone or maybe through any other kind of digital technology and device, in a more chat way than we currently do, which is more boxes and search engines, to actually really engage with their healthcare. Now, it may be some of the initial interactions could be automated, but actually there will always be a human in the cycle at the point that it's required as well. So I think the level of intelligence that we could power behind some of this, which ideally what that means is our scarce human capital across healthcare in terms of qualified doctors, nurses, AHAPs are used wisely, and resources such as diagnostics and beds are only used optimally when the patient really needs to be in that care setting and away from the hospital walls, in the community. And I just want to share the point, when I mean community, we know we talk about neighbourhood health being primary care. Healthcare is so much more. So it's so important in neighbourhoods. As it expands and it extends, it does bring in housing, social care, and other factors that also can contribute to an individual or a family or a kind of neighbourhood's health and well-being. And my key thing, I have a genomics background, so that's where I started my first career in decoding the human genome 22 years ago in a Cambridge Science Park. So you fast forward 22 years, that for me will be an absolute game changer, because being able to get either parts or your whole genome sequenced in a way that allows you to understand where you may have your predispositions as a part of your NHS data may help communities and care providers provide you much more effective and optimal care, in the knowing that actually you might be at risk from certain factors as well. So really changing the way that we've looked at healthcare from what is a utilisation service to something that is actually supporting you as an individual as a whole.
So to be clear, you are laying out there at least two massive pivots in quite short time frame. So a real hockey stick on, firstly, the consumer experience. So it'll be more like my Whoop that I love, which is easy to use and AI supported and handles data from my biome to my running to my sleep to my doctor's appointment. And secondly, that it will be more about risk and managing risk down, which is, by the way, where it should be, because we're the prevention podcast, not just reactive, symptom-led healthcare. And that actually we're going to start feeling that difference in the next few years. Do you agree with that?
Yeah, so I think the key thing is, as Sonia said, technology is completely different today.
Yeah.
And what we have the opportunity is iterative development. And we're very focused on, services for the NHS, designed by the NHS to meet their needs. And so, we have things rolling out from as early as this year, which are building out, not solving that, longer term vision, but, iteratively building our journey towards that. And whether that's in, pharmacies being able to record a vaccine, easy consent for vaccinations in schools. We've created platforms already which are really getting not only fantastic user feedback, but we're getting the adoption, and you'll see us really scaling those over the next year, 2 years. And then on the consumer point of view, we're going to build out through the NHS app that kind of status of all of your vaccines and all of your screening events that you should be showing up for. So people can clearly see and be reminded of what they're due to do next. Kind of, like you see in other parts of our kind of digital life, like what's my next best action? And then how can you bounce from that? Because we've done a digital health check also live this year, which will say, actually, you're somebody who smokes or you're somebody who's got weight problems, and how can we support you with digital innovations like weight management programs digitally, or talking therapies, to support you better manage your health?
Yeah, it makes sense. I mean, I have far better visibility of my car health than I do my health. So through the Volkswagen app tells me everything about my car's health, including when it's due, its MOT, its service, its tax, than I get from the NHS. Because James, right, we are the prevention podcast, but we do health and politics. That's what we do, and I know you both will have interaction with ministers as we used to be. What ministers want before the next election, and we've got figures out today, of course, because the social attitudes survey is out today showing a slight increase in public satisfaction with the NHS, but you've still got 3/4 of the population saying that they are either dissatisfied or very dissatisfied with it. They want to see the dial move on people saying, you know what, it's not such a struggle. It's not such a fight all the time to get the appointment, to get through, to nobody responding to my communication. That's what ministers want. That's the dial that's got to move. And I just wonder how confident you both are. I'll start with you, Helen. How confident are you when you sit down with ministers and they say to you, are people going to feel a difference by the time of the next election? Because that's what they want to hear.
Yes. And I am a firm believer in kind of innovation and driving progress. And I think, we use the app as the example because we've had, exponential growth on that. It's had a 300% increase in utilisation over the last 3 years. And, it's got massive kind of, we like to say, more than Netflix, massive number of people that are
Love that.
signed up. But I think you're absolutely right, because what we've shifted to in the NHS is much more being focused on the broader problem. It's not about an elective problem or a primary care problem. The problem is about access, triage and intelligent navigation. And we've got some kind of test sites in Sussex and London where we're looking at AI triage and how we can better navigate people to the right place, because you're not going to hit 90% of people getting same-day appointments when they need one. And managing that kind of capacity through GPs without using smart technology to solve it. So I think there's some really good results from that. I think as the NHS, sometimes we struggle with scaling and we have, pockets of really great work. Our job, I think, with the new investment is to make sure we can get that scale and really shift the dial across the whole system.
Just a couple more things from us. The government are currently working on the refresh of the workforce plan, so the 10-year workforce plan, which will come out at some point this year. Do you think that they understand that there is a now digital workforce that is different, complementary, sits alongside the physical real-world workforce, and are they involving you two and your respective teams in that work? Because they weren't with the cancer plan.
Well, before taking up the new role, I have been heavily invested in supporting the development of the 10-year workforce plan.
Great.
And clearly, developing the digital and data profession, having been head of profession for many years, is a real passion there it is. It's integrated into the future plans, and actually that is very, very symbolic. So it's not that we just need a digital and data workforce that supports the technology. It's pervasive. It's about how our people will work differently. It will also feel very differently around how they interact with patients and the public into using those technologies as well. It's been much more bolder about the type of leadership we need for digital as well, because digital is not an individual athlete or maybe park runner.
That's a great way of putting it.
But it's a team sport, and that team sport needs to be led by by the boards, by the leadership that are driving this. And not all leadership sits at board level as well, because actually, if you've experienced the NHS, actually quite a lot of the power and influence is in the front line, because you need to make sure that technology is meaningful at the point of care, and when you're trying, particularly in sort of red hot situations, trying to make a difference in terms of life or death as well. So it is integrated. I look forward to seeing it published on the other side as well. But the sentiments there are really around we need to get the right size and shape of the digital and data technology workforce. We need to ensure that we are creating the right skills and competencies across the wider workforce in play, and probably a new generation of hybrid roles that we've not seen before. And then also a real appreciation for actually what gets done physically versus actually what will get done more and more digitally as we embrace the technology that's available.
Brilliant. I love that, James. Digital is not an individual athlete. It's a great line. Yeah.
And in terms of, just another quick question for Sonia, in terms of what you have seen so far across government, have you learned anything, have you had any penny drop moments about, this is how other people have done it? Do you feel burning pride that health is actually out on the front and burning a new trail? What's been your reflections? I know it's only been 10 days or something. But,
yeah, easy now. It's week -1, my kind of official formal start is next week. There we go. Yeah. But having been connected up with peers, so my respective chief technology officers across government and other public sectors for now the best part of 2 years, there are very interesting timings of how organisations are moving. I genuinely believe that actually the statement around the blueprint for modern government really did accelerate.
It did, didn't it?
The pace and interest from wider leaders, not just the technology leaders as well. So I'm pretty impressed with where HMRC have gone around their path development, which is trying to create an ecosystem where they can do fast, test and iterative technology
really
alongside
and the single login.
Yeah, the juggernaut organisations that do exist as well. And then the MOD have done some pretty interesting things with such a huge environment that they're working in, that work in sort of very system of systems way, given all the different forces, around how they're creating an architecture that allows both for pace but also for quality in terms of the standards they need as well. So there are really some really good examples of, and what I am starting to see, and I could come back and discuss this more, is actually real pockets of where we're absolutely leading edge.
Can you give some examples? I know,
Maybe in the next podcast.
Okay, there we go.
Well, look, less than a week in, we'll definitely have you back because we'd love to hear your reflections a year on. But just sort of as we come to the end, I suppose, for both of you, in terms of reflections, gosh, I mean, Helen, if you could change one thing in Whitehall tomorrow to accelerate prevention through digital, without naming names, what would it be?
That is going to be really difficult to choose one thing. But I do believe that so much of digital transformation is about people and behaviours and how we work in a collaborative way across areas and across professions. And so the one thing I would definitely call out, that we need policy and delivery in the same room defining what the future looks like, so that we consider the whole problem. We get reflections, I think, from both sides, and we don't just consider digitizing what we do today, but we think about digital as a kind of true enabler for transformation. So that would be one, and then I'd quickly sneak in another one, which is basically I always feel that with prevention, and it's fantastic it is called out in the 10-year plan, but kind of incentivizing that whole kind of upfront engagement with the public to kind of drive that behavioural change, and potentially that's something that isn't there today to really support the prevention agenda.
I know, but intellectually I agree with you 1,000%. That phrase, behaviour change, I mean, it makes me shudder, because my own behaviours are terrible. They always have been. They were as a child, and it just makes me feel like I'm being told off. I know you didn't. Is
Yes.
there not a different way we can...
I'll get rid of the words.
Yeah,
I don't
I'm not
think
trying
it's
to
about
bring-
that.
I know it's not
actually
what you
think,
meant even, yeah.
Yeah, and it's probably not what I meant. I think what the key thing is that digital gives people, and I think people really like that, is feeling empowered.
Exactly.
And you can make a decision
Yeah.
not to do anything, but if you, a lot of the things, people don't even know what services they're entitled
I know.
to take up. So I shall get rid of that phrase almost forever,
Yeah.
because I think it is about people being empowered, and through that actually enabling the NHS to be more efficient, because people are able to more effectively look after themselves.
Yeah,
But it's
makes sense.
absolutely it's
I
a
agree.
choice.
Listen, there are some things that I feel I'm totally in control of, but there are many that I just think I'm doomed, I'm just trapped in some kind of, preordained, catastrophe. And it doesn't need to be like that. Even your dementia risk or your heart risk or your cancer risk, you can personally do things to change
Yes.
those. They might involve taking medicines. It's not all, eating more greens and papaya and what have you. And
5K
Steve's obsession
runs.
with star jumping and all
Yeah.
of that kind of stuff.
Papaya.
Yes, papaya. We'll talk about that another
Yeah,
time.
yeah.
So
very
West
keen
London.
on
He's so
papaya.
West London.
But
We're saying kimchi next.
I know.
Ooh.
All right, we can talk about that as well.
Do you like kimchi?
For my
I
bio,
do.
yeah.
For your
I do.
bio, yeah.
But the digital platforms, they do give you this connection and this it activates this sense of control. It's just such a revolution. I'm so passionate about that.
It really
you put
is.
it really well.
Sonia, just a final word to you. All the people here at this show, what would be your one piece of advice for them to do differently tomorrow than they did on Monday morning before they came to the NEC?
Do you mean to get a really big
Yeah.
NHS contract? Or no, I'm being serious.
If they can do that, good luck. But no, I mean, just in terms of mindset shift of digital, what would be the thing that you would send them away with a good piece of advice for tomorrow they didn't do on Monday?
Oh, I could write a whole book on this.
Well, you should.
Someone
Well,
did.
well, in my farewell notes to colleagues yesterday, as I've gone round Rewire, is just keep pushing for good, right? And that means ensuring that we're continuously looking at whatever we're doing to provide value to our nation's health, to make sure we're providing value to our patients, to our workforce as well, and our people. And by doing that and working strongly in partnership with industry, so let's just be honest, we do absolutely need industry to help us deliver the next agenda and the next phase of opportunities, is just to really work constructively in a way that provides meaningful difference. That would be my advice.
Well, that's a
for the
lovely
room.
place to end.
And Sonia, thank you very much for everything you've done for the NHS and for health generally. And Helen, thank you very much for all that you're currently doing, and good luck. I love your figures. Please send them to us and we'll get them on the website.
Brilliant. Yes, look, we've got a few minutes left, James. Just thank you very much to both of you for joining us. This episode, as we said at the start, is sponsored by Mastec. Full range of digital data and technology capabilities backed by partnerships with leading cloud system and data companies. You can find more on them on their socials or on mastec.com. Now, we're just going to finish, James. Martha Mills, young lady, she was 13 when she died of sepsis in 2021, and a coroner found that she would probably have survived with earlier intensive care. Her mother, Merope Mills, didn't write an angry letter about it. What she did was change the system, and we interacted with her when I was chairing the select committee in the last parliament. So Martha's rule is what she wanted to see, and what that does in a nutshell, it gives patients, it gives families a direct line to a rapid response clinical team when they just feel something is not wrong, and we know as parents, you just know when you know. And so in 16 months, over 10,000 calls, this is incredible, have been made. 446 led to potentially life-saving interventions, and one bereaved mother, 10,000 calls, 446 lives potentially changed. Fair play to Merope. What a way to honour her daughter Martha, because Martha's rule has really become embedded in the system, hasn't it?
Well, I would go much, much further than that. As a minister, I came across many of these patient-led campaigns, some of which had merit. A lot of them did honour those that had passed very thoughtfully. But this is an example of one where I think it's going to make a really impactful intervention on the way in which health is done, to empower patients and actually to instill in the system a fallback mechanism when things are going slightly wrong. I am very persuaded that rather than just being a moment of honour, this is actually going to massively improve the safety procedures at the front line of our health. And I'd like to take a big hat off to our Patient Safety Commissioner, Dr. Henrietta Hughes.
Henrietta, yeah.
Now, she has driven this one. When I first heard about it, I was a little bit sceptical. I did think it was a sort of Daily Mail stunt kind of level.
I agree, I did too.
And she has thoughtfully implemented it and taken doctors and the system with her. And those telephone calls haven't become a tsunami of harassing administrative FOI-style red tape screw-up. Actually, it's been embedded in a very, very thoughtful way, and I think will be seen in outcome data further on as significantly improving the lot. So hats off to Henrietta.
Yeah, and Mum speaks so brilliantly and coherently on this. I've heard her on national radio many times talking about it. If we could create a rule, James, the Bethell rule. What would the Bethell rule be?
God, I don't know.
To
I didn't see
transform
this
prevention?
until just now.
Yeah.
I think it would be this risk point that both Sonia and Helen referred to. I would like people to know and understand their risk of later disease and have some kind of rule about having the facility to know that risk and to have options for modifying it. That, for me, is the central debate.
Yeah. Not everyone wants that, of course.
It's true. Funny enough, my brother, who won't thank me for bringing him up on the podcast, absolutely does not want to know. He will not do his DNA. He doesn't want to know his cardiac risk. Yeah, he's happy living the life he's got.
Yeah, the Bethell rule.
But it's not wise. I keep telling him. It doesn't go down very well.
Love it. Yeah. The Brine rule was, when I was in the department, the officials, we put through the sugar tax. I wanted to put through a salt tax to reduce salt in our diets, and particularly in processed foods, which, given my surname is Brine, amused the civil service greatly. So that probably wouldn't be my rule. My rule would be to manage population, for population management, to risk stratify, and we don't do that very well. I mean, going back to the days of your family GP, they used to manage much smaller lists, and therefore they managed them more tightly, and they were able to dip into them and really sort of manage your health holistically. And all the evidence suggests that the smaller practices with the smaller lists have better outcomes, and so that's where the Brine rule would probably go.
Very good. Well, both of us have actually come up with policy priorities rather than rules. I'd like to challenge the listeners. Can you come up with a really good, proper rule, like Martha's rule? And if anyone can come up with some good suggestions, we'll read them out next week's show.
Yes, and on that point, just proving this is not just thrown together, it's preventionisthenewcurepodcast@gmail.com. You can find us on all the usual social media channels, and many do. Please get in touch. Tell us what you thought of the show. Tell us what you'd like us to talk about in future. In the immediate future, James, next week, you're going to be on your own.
I know. I'm going to have an amazing guest.
Oh, yeah.
They don't know who it is.
No,
and nor do I. But I promise you it's going to be amazing.
Okay. This has been Prevention is the New Cure, the Health and Politics podcast with myself, Steve Brine, and James Bethell. Thank you so much for listening live from Rewired Digital Health at the NEC.